Good evening and welcome to the next episode of All Things Spinal. I am your host, Thomas Deckers. I'm a spinal specialist physiotherapist here in Cork in Ireland, and I'm delighted to be joined this evening by Kieran O'Sullivan, and we're going to be talking all about psychosocial factors related to low back pain and to pain in general. Kieran is a professor of physiotherapy and the head of the physiotherapy program at the University of Limerick here in Ireland. He's a very esteemed researcher, has published some hugely influential work around low back pain as well as other areas of the body. He, as a disclaimer, he's also, I know Kieran quite well personally. He is one of my long-suffering PhD supervisors, who's been fantastic with that. He's arguably one of the smartest people I know, and also a very humble and great guy. So we're delighted to have him on. I consider him both a mentor and a friend. So, Kieran, welcome.
Thank you, Thomas. That's quite the intro. I feel like I have a lot to live up to.
No pressure at all. No pressure at all. So, Kieran, maybe to start off, it's always good, I think, to give listeners and viewers a bit of a background on yourself and how you've come to do what you're doing at the moment and that sort of thing.
I met some friends from college last weekend, and we were reflecting on the fact that it's pretty much 25 years since we graduated as physiotherapists. Unfortunately, they still have a lot more hair than I do. And, when I qualified 25 years ago, if I reflect in time, I could say that, the evidence in physiotherapy has evolved a lot. And it has, but actually a lot of what I'm going to talk about tonight was actually known at that time in the late 90s, but it hadn't really kind of filtered into practice. And so when I first qualified, I trained as a physio and I really enjoyed my work, but it was very much focused on the traditional models of pain. And I suppose my understanding of pain is continuing to evolve. And I suppose that's one of the biggest gaps I feel in my own practice, and I think across the profession, has been a limited or tokenistic view on the importance of psychosocial factors in health and in pain. And that's probably why I sometimes get pigeonholed for these kind of talks. I sometimes have to remind people that it's not only the psychosocial factors, but I do think it's probably an underappreciated part.
Yeah. And we had a discussion offline about what would be good topics to discuss, and you're obviously an expert around this area, but it's certainly not all you do. There's plenty of other strings to your bow, so to speak. But for this evening, we're going to jump into psychosocial issues, and on reflection, personally, and reason we kind of decided on this is because it is arguably one of the most it's a huge clinical area that I think we all need to know about, but it's also one of the most misunderstood areas, I think, in clinical practice. What are psychosocial factors? People can get to be put into certain buckets or labels that may not be appropriate, and other times we miss them completely. So maybe as a good starting point, Kieran, maybe you can clarify for us, what are the psychosocial factors?
Sure. So when you go back to Engel's model of the biopsychosocial model of health, he had a very all-encompassing view of psychosocial factors in terms of being anything from any of your thoughts, any of your emotions, or any person, thing, or environment that affected you. So from your worries and anxieties to your mental health, mood, anxiety, right down to the people you live with, your friends, your hobbies, your work, the neighborhood you live in. And so that's very, very broad and all-encompassing. And again, that doesn't mean we can change all those things, or it's a physio's responsibility to change them. But I suppose that original model was just around thinking broadly, scanning the horizon for everything. And then obviously some things are going to be more relevant than others, more amenable to change than others. And so when I think about psychosocial factors, it is in the same way, I suppose we would say that we'll triage for red flags. We should triage for some of these other kind of factors. And they won't all be relevant, but at the very least, ask about them. And I would say, if there's one thing I won't tolerate, it's the idea that we shouldn't even ask about them. That doesn't mean we mightn't be the right person to help them, but at least ask.
Okay. And we'll get into that later about how we ask it, which is, I think, an important point. Personally, I like to maybe think of the relevant ones in a number of different buckets. So I might think about the psychological factors or the psychological disorders per se as being, depression or anxiety disorders, the social maybe issues around work, home, social inclusion, friends and family. And then maybe the third bucket might be your cognitive behavioral, which might involve things like kinesiophobia. It might involve things like fear avoidance. It might involve things like catastrophization. Would that be a fair representation? Keep as a disclaimer, all will present together, but maybe as a way of clinicians helping to make sense of it, or are we missing?
No, I think it's reasonable. I don't sweat it, to be honest. So, for example, that seems reasonable. I know some people will say more strictly, they'll say psychological is cognitive or emotional in the pain literature. But even if we look at the other end, we talk about social. So we're talking about socioeconomic, social support, social friendships, or is it ethnic and cultural dimensions and a whole series of other things? And again, I guess, look, I'm neither a psychologist nor a sociologist, so I'm sure if they heard me talking about psychosocial factors, they would quite rightly say what I'm talking about is a broad, superficial view of these factors, because I will never be an expert in the assessment or management of these conditions. There's no psychological diagnoses being made. But it's just that we are traditionally so far away from looking at them. All we're really saying is, look over there. Don't ignore them. Again, because they are part of that picture. And then I'd be open with people using any form of kind of categorization in their head that makes them comfortable. So, for example, even in terms of management, which we'll come back to, is this like something that's totally amenable to primary care, rehab people, physios, chiropractors, etc.? Is this something that they'll need a little bit of support, a small bit of counseling, what we might call light touch mental health support? Or no, this is at the other end of the spectrum, acute psychiatric distress. They need emergency department referral, psychiatric care, maybe even inpatient care. And so like there's a big range of kind of risks in that. In the same way, when we look at red flags, back pain at night is technically a red flag. But we don't send everybody with back pain at night for an MRI necessarily. It's kind of taking in a range of factors. And I guess that's why, again, I like the idea of the breadth of these factors. Tim Wiedemann in Canada, and I might be mispronouncing that, but I remember him presenting at a conference many years ago, looking at the cumulative psychosocial risk index. That idea that if you have depression, yes, it's a bit of a risk factor for pain, but if you have depression and loneliness and poor socioeconomic status and fear, your relative risk of pain and disability into the future keeps ramping up. So ask about them all. And then, I don't worry too much about the I suppose the categorization piece, but there obviously are people who would.
Yeah. I think it can be helpful sometimes to maybe subcategorize a bit to help just parcel your thinking, because it is such a big area, and it just maybe from a honing your thoughts down towards what are the relevant factors, because you can be hit with a huge story with patients, which is, we want to delve into that. And then the question is, what are the most relevant pieces really? Because at the end of the day, everyone has psychosocial factors. Everyone has psychosocial things going on in their life. When do you start to consider them relevant for someone's presentation?
Sure, because it's a fair point that none of us will go through our lives without, having some psychosocial factors, positive or negative. That's just the nature of life. And something as benign as being under pressure and feeling rushed and feeling there's not enough time to do things, you could consider that a psychosocial factor, even if it's also part of normal life for some people. So I think, again, what we're talking about, I suppose, the person is presenting with pain, and by the fact that they're human, they'll have a psychosocial factor too at some point in their life, at least, as well. But are those two things connected or not? And so one thing we're going to do, first of all, is ask about them, get their story, as you were saying, and see what's going on in their life. But then trying to see if there are any patterns. And that might be connecting timelines, for example. Once we've established, look, the person said there have been times when I haven't slept well and I've had high stress. Is there any relationship in terms of timelines with their pain? So the person says, look, this pain started last November. What was going on around that time? Any other changes? And if it might be a separate part of the conversation, they mention, well, I had exams coming up around November, December, didn't have much time to exercise. That was a period of time I didn't sleep or eat so well. and there seems to be some parallels that can be both insightful for us, but it can also be a useful learning kind of experience for the person with pain, if we truly feel they're connected. But for there to be a relationship like that, we'd like to see that pattern repeating a few times so that we're happy it's not just a coincidence.
Sure. And again, we'll get into this maybe more when it comes to drawing that story out, asking patients, whether they see that kind of association between different periods of their life and different things that were going on and their pain can make them think, but other patients may not be that introspective and they may kind of gloss over them. So sometimes I assume we'll have to delve into that, and sometimes it won't. I mean, sometimes large periods of stress or anxiety may not be related to their pain. Would that be a fair point as well?
Absolutely. And we'd be lying if we said we understood this. So, while we will see the person with pain who might have had a flare up in stress and anxiety, and that might truly be a trigger for their pain, and I would consider that to be, reasonably evidence-based, we will see people going through enormous stress and anxiety, and they might develop other health complaints, but not pain. So this is not a black and white issue. If only life and humans were that straightforward.
I know. Okay, well, look. Okay, so that gives us a nice broad overview. What I think some of the reason why this topic gets a bit lost or a bit misinterpreted is because I think some of us or clinicians find it difficult maybe to associate, maybe even from a biologic point of view, what is that link between psychosocial factors and that person's pain. I mean, so there is evidence to suggest that depression, for example, coexists a lot with low back pain. I think there's still debate whether it is a causal factor. We do see people who have pre-existing depression who are more likely to get back pain. Does that mean that the depression causes the back pain? I don't think we're there yet, but maybe, Kieran, would you help us understand the physiological link, if there is one, between, or what we think is happening with life stresses and people's pain?
Sure. So I'll break it up in two parts, because I'll say this, you're actually asking about the second part, kind of what do we know about the biology and the mechanisms. And the reason I'll come to that second is that I think that's the answer for the healthcare professionals, the researchers. So we like the idea of understanding it. The reason I'm going to talk about something else first is that I've never had a patient come in and say, I'd like to understand the mechanisms. They just want it to be plausible, sound sensible, and logical.
Yeah.
So I'll come back to the biology, but I suppose just to reiterate that while I think, for example, I've learned an awful lot from reading Louis Gifford's books on aches and pains, and even Lorimer Moseley's great stuff on explain pain. And I think that's really helped me understand some of the biology, neurobiology of pain. With patients, my explanations to them are much more around really basic things, like when I get run down in terms of being stressed or sleep deprived, I will get cold sores, my rosacea will act up, or sometimes people will get headaches, some people will get high blood pressure. And when we discuss these things with patients in a non-judgmental way, they're quite comfortable with the idea that, yes, headaches can be linked to psychosocial factors like stress and sleep, and high blood pressure. Yeah, I hear people talk about how that can be linked to stress. So when it's not said as a judgment, like when it's not, Thomas, I think you're a bit of a weak individual and you're lazy, and when it's not linked to kind of judgments and stigma, people conceptually are quite okay with the idea that health in the broader sense can be influenced by life and crap like stress and sleep and mood and all those kind of things. But it's just that it can be handled insensitively, and that can lead to some kind of resistance, understandably. But we'll come back to, I suppose, how we handle that in a second. But your actual question was around what do we know about the biology. So again, a major caveat here, I'm not a basic scientist, and my answer is going to be a little bit superficial, though. From my reading of the literature, we know that a whole range of these, what might be deemed non-biological factors, are actually having truly biological effects. So I still describe it as the biopsychosocial model because that was Engels' term, and I see it as being very useful. But those three parts of the biopsycho and social, they are a Venn diagram and overlapping and interacting with each other. But if we look at any one of those factors, whether it's, let's say, sleep, we know that sleep deprivation is strongly linked to altered immune responses, altered biological processes like stress hormones like cortisol are affected. If we look at things like depression, sleep, anxiety, we see similar mechanisms that they strongly alter, let's say, whether we want to call about pain sensitivity or baseline inflammatory mediators, we see significant changes. And in fact, what probably makes it messy is that they seem to interact with each other. That things like, for example, stress and sleep can cause low-grade inflammation, but actually higher fitness and physical activity can moderate that increase in inflammation. And that's probably one of the reasons why, if you asked me 20 years ago, why did exercise help people with back pain, I would have said things like made muscles stronger, made them activate a bit more. I still want to get people strong and fit and flexible, but I think that at the kind of intensity of exercise I'm typically prescribing now, it's probably having much more of a systemic, low-grade anti-inflammatory and mood-altering kind of an effect. But on that point, what I've just said there is highly hypothetical. One of the reasons that is to really understand that you have to do kind of mediation analysis. And without boring people to death, what that really means is start treating the person now, today, and then not just see how they are in 3 months, but measure these potential mediators like inflammation, mood, fear, fitness repeatedly throughout. So you see what starts to change earliest and before their pain changes. Because obviously, if you see a person now, and if they have surgery, an injection or physio, but they're better in 3 months, not only is their pain better, their mood's going to be better, their sleep's going to be better. And that mechanistic work, we've got a paper coming out on that actually soon in the on the Restore trial. But again, it's only looking at some factors, but it's very time consuming, and for that reason, we don't do an awful lot of it.
Yeah. No, I think you've really summarized it brilliantly there. And I think what's also worth reiterating, which is what you did, is that a lot of this we don't know. And having had my head buried in a lot of this literature, I've been kind of searching for maybe more of those plausible links from a mechanistic or physiological, and we don't know. It's just not really out there as much, certainly regarding stress hormones and certainly regarding pain amplification, we know, but the mechanisms of how it's done, I think, are tentative. Maybe certain brain regions and things can get more activated and things like that. But I don't think it's as simple as that. Is it really? We know that pain is a conceptual entity. It has contextual factors, physical factors. There's a whole host of things. So what impacts someone's pain is almost very hard to trace in a study, I'd imagine.
Yeah, and we come up with new terms. It's not that they're wrong, but like if you look back to Louis Gifford's kind of mature organism model, most of the newer information we have still fits with that idea that you've got, existing beliefs or whatever word we're using for that, the context, the environment, the stimulus. And at the end of the day, it's the person in front of us we're treating, and we're going to try and figure out what works for them, what's I suppose a factor in their life. And I suppose in one sense, what I've just described there can sound very messy. So, it could sound to clinicians, it's like, oh, Jesus, this is awful complicated. It's stress and mood and anxiety. And then there's movement and exercises and manual therapy. Whereas actually, I suppose if I listen to people like Peter O'Sullivan, who's had a big influence on me, he really brought home to the idea that this is good news because we have multiple inputs. So, no one treatment's going to work with everybody. But actually, if you've got somebody where they've got a mix of contributors, which is often the case, well, look, maybe exercise is an option for them. Maybe some sleep hygiene or sleep restriction is an option for them. Maybe some mindfulness and stress reduction is an option. Maybe improving their diet's an option. And in any one practice or clinic or hospital, you're not going to offer all those services, but you probably offer some. And we can often, I suppose, kind of give ourselves an easy out by saying, oh, if only now we had the hyperbaric oxygen chamber or the clinical psychologist or the multidisciplinary team. But in reality, most of us are going to work in settings where that's not all available. But what have we got? And what can we do to, I suppose, help people a little bit? Because as we'll come back to probably in a while, when it comes to and this is a tricky word to talk about, but my treatment of psychosocial factors as a non-psychologist, a lot of that treatment is really undoing stuff and doing a really, really basic step, almost resetting people to where they can just start the natural history of healing, as opposed to it being exacerbated and compounded by their own environment or maybe even the beliefs people like me have given them in the past.
Sure. So as maybe a summary of that area, would it be fair to say that certain factors in people's lives and other aspects may lead to them having thoughts, emotions, behaviors that can then amplify or at least modify their pain. Would that be the essence of psychosocial factors?
Yeah, I think it is, and I guess, like we'll say, there's good hard biological evidence that these things really have a biological effect. So, for example, there's sometimes a risk that people think, well, if you think a certain way, then you'll think your pain is bad, and that's how they're connected. But even if you look at things like, people who are given the flu jab when they're sleeping well or sleep deprived, the degree to which the flu jab protects them against the flu virus when they're exposed to it is quite different. So there's hardcore biological immune effects and physiological effects to this. So it's these are anything but imaginary. And so while, again, I'm calling them psychosocial as if they're separate biological, they're intimately connected. The reason I put a bit of an emphasis on them, because you could argue it's all biological, is that when we think bio, we strongly emphasize the biomedical pathoanatomical aspects of it.
Yeah. And as much as Engel had good intentions, and I agree it's a very good model, it does tend to the word biopsychosocial tends for us to try and think in three different ways, and really, as you said, it is a Venn diagram. There's an overlap between all of them. One will affect the other. In certain patients, bio or psychosocial will have bigger impacts maybe, but they're all going on at the same time.
Yeah, and I think it wasn't his fault, but it's almost a natural consequence of looking at three connected parts that will, especially if you think of the training of a lot of musculoskeletal practitioners, it is understandably more focused on the bio.
Yeah, which probably leads in nicely to the next area I want to discuss, which is why is there this, at least in my experience, there seems to be this persistent stigma attached to psychosocial. So certainly when I qualified 16, 17 years ago, there was, we would see patients when I was a junior physiotherapist, and we all wanted to see the nice, easy, nociceptive patients. As soon as someone came in with more complex pain presentations, you would immediately label them, or they were labeled as yellow flag, and your head would spin a bit, and you go, oh God, they're not going to respond. And that was very much the thinking, that those people who maybe didn't have a nice, clean, nociceptive mechanical presentation, who maybe had a bit more fear or anxiety around their condition, were effectively labeled as those who weren't going to do well with physio. And of course, as my career went on, I've learned to manage that. But it still seems 16, 17 years later that some clinicians are quite daunted by this. I see maybe a lot of clinicians maybe even getting burnt out a bit by taking on these psychosocial issues, and maybe feeling like they have to cure them or manage them. Like, why do you think firstly, do you think it's still stigmatized, the psychosocial factors, compared to the physical?
Sure. Because there's a couple of points in that. If I deal with the last one, I've seen some people almost talk, and like everything, Twitter is an echo chamber in its own way. And I've seen some people argue on Twitter that like the pendulum of the biopsychosocial model has swung too far. That angle is right up there with some of Donald Trump's statements in terms of its ability to rattle my cage, because it's a million miles from any kind of reality in which I see patients. Societally, and this applies in every country I've seen patients in and taught in, we strongly validate and appreciate the biological components to most health conditions, but particularly the musculoskeletal pain stuff we think about. So, for example, if here I'm in East Limerick, or if you're down in Cork, and if somebody was in the pub down the road tonight and their back was a bit stiff, if they turned around and said to somebody, "Oh, I'm a bit stiff, I think I'll go to the GP or the chiro or the physio tomorrow to have it looked at," people would say, "Yeah, fair enough," Whereas if they turn around and said, "Oh, I think I need to see my psychologist again," they would get some funny looks. And there's a chance that, the evidence-based psychologist and physio mightn't offer such different treatment and advice. But there's that sense that pain is, the dualistic model, it's body or mind. And look, we all thought like that at one point in time. I'll even still see patients where when we have discussion and they can see, again, the contribution of multiple things. So there will be inactivity, very stiff, guarded patterns of movement and physical avoidance, along with some of these psychosocial factors. there is that sense to which it's more comfortable for them to frame their problem, especially with others, in a biological lens. I've even seen this when it comes to like discussions with others about acting as an expert witness or being involved in medical legal claims. So to give you a semi-hypothetical situation, take say a worker who's had a workplace incident. I won't even say injury. They develop some back pain, and there's a medical legal case pending from that. They have an MRI scan showing disc degeneration, and there'll be various kind of incident reports and inspections. And let's say you get two angles that come in, and one of them says that the height of the disc they were working at was 2 centimeters too low, and the angle at which they were working was slightly suboptimal. That's one report as a contributing factor. And the second report was from a management consultant, which says there was a toxic work environment. There had been a string of redundancies and pay cuts in the recent 6 months, and a long history of bullying and harassment and you name it. In the eyes of a judge or a jury who's making decisions around the company being negligent, I have no doubt in my mind that the ergonomic assessment will be seen as, well, that's negligent. And this other stuff, that's horrible, but like that's got nothing to do with this person having the disc degeneration. And I don't know how we turn around that anytime soon. So like, it's a really tricky one. So I think that's why we've got to get comfortable with our kids and primary teachers and kind of a community kind of an awareness of health, that it's not physical or psychological. Sometimes obviously it could be more one or the other, but that these things are intimately connected. But right now we are at that situation. And that's why I think it's perfectly fair to be sensitive to how our message could be picked up by people. Because the very last thing we want to do to people who are already feeling sore, distressed, maybe isolated, maybe judged, maybe dismissed, is to give them the sense that, oh, I think you're one of those. And going back to your comment about the patients, Tom, this was absolutely my own experience in that, it was lovely to see the people who came in with, a callus fracture or a smile sprain, a bit of a stiff knee, because they came in, they turned up on time, they did their homework. And when I asked them, how are they? They'd say, oh, good. And how was your day? And we had a two-way conversation. And then they brought in a box of chocolates or a pair of socks at the end of the treatment, and it was all lovely. Yeah. And that was much easier than the people that when they were sent the appointment, sometimes they didn't turn up, or they turned up late, and then they complained that the exercises hurt when like these aren't hard exercises. And then they said these weird things that weren't dermatomally distributed, and then they were kind of draining to be around sometimes. And again, I know that can sound like I'm being mean towards the patients, but in my ignorant way of viewing things, these are hard patients to see. And sometimes, while I don't think I was ever overtly dismissive of them, sometimes I did start questioning their motivation and like them being the tricky patients. And I suppose even if we look at it from the research perspective, there was a fabulous trial done quite a while ago by Nadine Foster and Jonathan Hill and Keel. It was the Startback trial. And there were several things about it. But one of the things they did in this lovely trial, they compared stratified care. So one arm got either a low, medium, or high amount of treatment, depending on how high risk they were. And the others then were sent into a sensible NHS system. But what I want to focus on is the NHS system, because the idea was that obviously the low risk ones would get one sensible piece of advice. The medium risk might ideally, get a bit more, and the high risk would obviously get the most. And what they found for lots of places was it was the opposite. The low risk people got loads of appointments, and we know afterwards they didn't do any better. And the high risk patients often got discharged after one session. And when you think about our discussion, I think that would have been me years ago. The low risk ones, they're not bad, but sure, they're nice, and sure, they'd like another session. What's the harm? And then the high risk patients came in, they said these weird things. I'm not sure, all that bilateral pain, maybe they've caught equina, send them off for scan straight away. Or actually they said this weird stuff, and they have some IBS as well. Maybe they should go to see get a scope of their tummy before anything else, or get to see a psychiatrist, or their pain's so bad they need to go back to the GP. And so that there's those two things. We can stigmatize and dismiss them, but it's genuinely tricky. And I guess one concern I have, it's a legitimate criticism maybe of the message I'm pushing, and again, I'm only advocating what others have taught me, is there's a sense that we might start making clinicians, and I'll say physios, but clinicians broadly, make them feel like they must solve everybody's problems and place a big burden on them. I was talking to somebody recently about how they were talking about GP practice and how, as a GP, 5 days a week of seeing people is very hard. And they were basically making the point that 3 days of GP work and a day or two of other work in a less, maybe a less intense, atmosphere might be good in terms of career longevity and avoiding burnout. And so I think the work that we can do and help people with persistent pain is very meaningful, very rewarding, but it's hard and it takes time. And I would have concerns about, even in some countries, Ireland isn't too bad, even though everybody would like more money. The remuneration schemes in some countries are absolutely incompatible with what I'm proposing, where it's like you'll get paid the same amount for seeing the patient, whether it's 15 or 30 or 45 minutes. So patients are getting turned around very quickly in 15 and 30-minute sessions. So I know I'm veering off topic there, but there is that sense that we'll say there's a big stigma there. We want, as physios, to be more open to discussing them, but it's a big challenge. And my sister-in-law is a clinical psychologist. When they start talking and dealing with patient representations, obviously some of it is more severe and worrying, but there's a big thing on protecting their own health and journaling and discussing with others how it felt to have somebody unload on you like that. And I think at times I've been guilty of asking things and taking it all on board too much and kind of being a bit traumatized in the excessive word, but kind of it having an impact on me and not being able to figure that out. So there's things I think in our post-grad training mentoring that, as I think we go down this road, we probably need to just think about how we look after ourselves, because we want people to be good at this, but also to keep them in those roles then.
Yeah. Look, you raise so many great points there, Kieran, and that stigmatization, yes, is probably at a societal level. So as we're going in, before we become healthcare professionals, probably have this idea that a lot of the issues we're seeing are physical or biological, even though we've just discussed that biological and psychological interact. But ultimately, at the end of the day, when my training those years ago, I don't think there was any mention of psychosocial factors, not in the same way that we're discussing them today. And then when I went out as a junior physio, I probably felt very unequipped for that. There was just no real conversation around that initially. You had to pick it up as you went along. And I think so much of that is down to the education maybe of undergraduate clinicians. And how do we see that that's improving? Because I had to reflect, I look at Waddell's work, that's over 40 years old now. And he's, so these are conversations that have been going on for decades. Yet are we really, I suppose we are, and I think physios have to put our hand up and say, look, we've been very good at trying to integrate this. Are we still preparing people really for dealing with persistent pain at an undergraduate level? So when they come out, they know the lay of the land.
Yeah, no, it's true. And I think that Waddell, that's what I mean. Like, some of that language is there for a long time back, and it would have been there in college. And if I really think back, I do remember hearing at the odd lecture things about occupational vocational rehab programs for persistent back pain. It was mentioned in lectures for sure. And I'd say
non-organic signs.
Non-organic signs. Yeah, some of that stuff. So some of that language was definitely there. And I think this reflects the limits of my job. I don't think any of that stuff really gets embedded in lecture. I think where that really gets embedded is in the clinical practice placements, and that's why they're so important and so valuable. And then obviously in your post-grad career. And that's not to give the academics a path out, but I almost think it's like anything in life, you have to reinforce the message consistently throughout. So for example, if we want to give a patient the message that exercise is safe, we shouldn't do 20 minutes of manual therapy, 2 minutes of exercise, and then expect them to see the exercise as a key part of that program. And if we want students to really appreciate it, they have to hear this message in a lecture, in the practicals in the university, be exposed to that in the clinic, and then see postgrad opportunities where you can develop those skills. Whereas again, a lot of the postgrad opportunities I see are much more in the techniques kind of basket, if you know what I mean.
Sure.
And I guess even if you look at, we'll say, when we send our students out in placement, there's even healthcare, I suppose, prioritization challenges. So the kind of people I'm picturing are the classic persistent back pain, but it really could be persistent hip and knee and shoulder pain as well. But in the persistent back pain, and if you're in lots of parts of Ireland at the moment, if you're not after having a fracture, not urgent, not post-op, not after having an epidural, you'll be on a long-term waiting list. It's not an urgent priority. And so people with, troublesome but short-term problems like a callus fracture, which is healing fine and is routinely coming out of its immobilization, they'll get prioritized further. The reason I bring that up is our students will be much better off seeing the disabled long-term fibromyalgia, persistent pain patients, and looking at the complexity of that in a supported environment than seeing some of the relatively routine stuff that is, I would argue, sometimes considered safe for students.
Yeah. Yeah, no, you raise great points there, Kieran. And I think about that postgraduate mentorship, and I suppose a lot of people would say in-service training, but truly to make the theoretical, to show practical examples of the theory and show how psychosocial factors are in clinical practice really is on a patient-by-patient basis. We can discuss what catastrophization is, for example, in the classroom. Seeing it in real life is a different story, and managing it is certainly a different story. I was reflecting there. My mother too is a clinical psychologist, and I look at her, and her training is to deal with these things. People come into her, and she is digging for psychosocial issues. People are coming in to discuss those. In physiotherapy terms, possibly in medical terms, people always think that there's a physical problem, and now we're sprinkling a bit of psychosocial on top. But really, from an education perspective, early doors, we need to have that conversation early, that we're dealing with birth, with both really. So
on that point, I am only half joking when I say that, if you're going to see a psychologist, there's nowhere else, I'm going to talk about things, thoughts, moods. Yeah. Whereas when people are coming to physio, I'm only half joking that I say when people come to the door, they're starting to strip, to get ready for the rub,
Yeah, absolutely. The difference, I suppose, is my mother doesn't give exercises, right? She stays in her psychological lane, inverted commas, and she sticks to that. And if someone says, "Are you going to show me some back exercise?" she'll say, "No, go see someone else." So physiotherapists and other healthcare professionals, certainly in musculoskeletal health, have to be able to have a degree of awareness of psychological issues and be able to manage it in clinic, because there's a level at which we'll consider referring on for a psychological help or other help, and we'll discuss that in a minute. But it really is asking us to step up a bit, because this is real life practice. This is really what's on the ground, and those nice, clean, simple, nociceptive mechanical patterns are a proportion of people's musculoskeletal caseload. But if you're in practice for long enough, depending where you are going to come across people with considerable psychosocial factors, and to shy away from them or to say, look, that's not for me, is maybe less than what we can really offer. And the profound thing is that, as I've learned, certainly from working with yourself and from others, is that when you start to get into this stuff, it's really fun, really engaging. Fun is a strong word, but it really does add a different layer to your practice, to delve into someone's story, to be able to change behavior, to be able to change thinking. It's a great skill. It's a very excellent clinical tool that we have in our tool basket. Maybe one of the best that we have.
It is, and it's not exactly what you're talking about there, but I do honestly think that there are times when we have really excellent clinicians who are all out trying to help their people. Sometimes they need to be protected from themselves in terms of how much they put back into it. The example I was given to someone recently is that in an Irish system, it'll be different in other places, but we have people working in, say, triage roles, excellent people, but actually a lot of the time then they're not intervening, they're directing traffic and making high-level decisions. And we have other people then doing rehab, which is very time intensive. And I actually think both of those groups of people might better from job sharing with each other, where you got an element of high-level decision making and triaging, but which is on a kind of, it's not as personally draining, I would argue. And then equally you got a taste of that rehab once you have triaged the people in that direction.
Yeah, I feel very fortunate in my role as triage. I'm in neurosurgery, so I will see people coming in for a neurosurgical clinic. I will triage them, and I really feel like I use a very different part of my brain compared to then my rehab, either here in private practice or in the hospital. You really get into someone's story. You really use different skills, and a degree of both, I think, is really good.
And that allows you as well, because in any profession, people can they can want something fresh after a while. So having different elements of your skill set allows your own kind of growth and interest to kind of be focused in one way or another.
And job satisfaction, yeah. Okay, so look, that's the big picture. let's talk about how we manage this in clinic. We've kind of alluded to certain things. What do you think are the most relevant factors if we were to kind of deduce this now? What are the most relevant factors, the low hanging fruit, Kieran? So
Sure.
what do people need to know in clinical
So
practice?
I suppose my main thing here is that a lot of the things that I call social factors, psychosocial factors, once we discuss them, a lot of physios will feel, oh yeah, I can handle that stuff for sure. Because two of the most common things I would do in terms of addressing psychosocial factors is reducing catastrophizing around how bad their MRI scan is or how dangerous movement is, just de-escalating the fears and the anxieties based on what other people have told them, and then reducing their fear around movement. So helping them to understand how movement's safe, showing them, practicing that, reinforcing it. So if we step back and look at we'll all be familiar with the idea of people being told their disc is so badly damaged, there's narrowing, there's all these terms that they don't understand. And that is catastrophizing, and it is hypervigilance, and it is a source of worry and anxiety. And I suppose a biomedically trained person is like a physio, a GP, a radiologist is much better placed to address that than a clinical psychologist. And equally, in terms of fear of movement, while that is fear is a psychological trait. If you look at taking somebody, the classic person who's bracing, guarding, afraid to move, holding their breath, gritting their teeth, of course you can reassure them and highlight their fears and anxieties to them as a psychologist. But the great Steve Linton himself would have commented to Peter O'Sullivan before that the key difference there is physios can touch people, facilitate movement, and have a greater confidence in exercise prescription. And so in those arguably not the most severe, but I would say the two most common psychosocial factors I see in patients, catastrophizing around, is it safe to move, or is my scan so bad and my disc is so badly damaged, and the actual practicing of restoring movement that is feared, avoided, hyperprotective. That's totally, I would say, in the skill set of physios, even if they haven't done any complicated post-grad, psychological training. Then we can talk about, I suppose, more severe cases in a while. The other one I think that I'll often remind people about, that's an easy one for physios to upskill in, is the whole area of sleep. And I raise that because, sometimes things can get very territorial. I know in some countries, including the United States and so on, there's a kind of a degree of, well, who can do manual therapy or manipulations, and who are the exercise experts. Is that in Australia, there's exercise physiologists, we have athletic therapists, athletic trainers, obviously a whole range of people with strength and conditioning qualifications, and like people like yourself with multiple clinical and, S&C qualifications. And then there'll be people who are experts in diet, people like we mentioned, psychologists, psychiatrists in the mental health space. But sleep is one of those big gaps. And it's something that loads of our patients report. And I would say that nobody really owns it. And so, first of all, it's a known risk factor. It's something that is modifiable. And so I would argue it's a thing that healthcare professionals and physios are suitable as well, that they should kind of engage in it. In fact, we're running a training event face-to-face and online in the middle of April, and people can find out more about that if they want. But I would say it's a modifiable factor. And again, it's very much within the wheelhouse of physios. The other thing is that it's often a kind of a nice entry point to even discussing feelings and thoughts and worries. So, for example, people will often, without even knowing where you're going, when you ask, so how's your sleep been? They'll say, oh, I'm never a good sleeper. And that opens conversation about for how long and why, and do you notice, are there patterns as to what you're thinking about when you wake up, and so on. And that can open up a bigger conversation, as opposed to asking flat out, are you a worrier? Are you anxious? Do you have depression?
Okay. And so the three big ones really you're talking about there are to be on the lookout for fear of movement, catastrophization around their diagnosis or their scan, and sleep.
Yeah,
and as you said, go on.
Sorry. No, you're good. Sorry, I was just going to say, and with that sleep one, I suppose I probably threw that in there almost as a kind of a reminder of people that psychosocial factor is very broad.
Yeah. Okay, great. So people can be on the lookout for them, and I think it's helpful for people to at least be able to hone in on this if this is new to their practice or they want to integrate it initially. And I think we could all tell when someone is worried about their scan. We can all probably tell when someone is fearful of movement. I saw a gentleman yesterday who was in a bit of pain, and he was quite verbal, just to say, I'm just afraid to bend. He's a few months post surgery, and he's had a rough journey. But some patients will be verbal about it. Other patients, you'll see it. What would be the classic signs you would see with someone who would be fearful of movement, Kieran?
Sure, it'll be so. Some of them sometimes they'll verbalize it, but at least as commonly they won't really think that they're afraid of them. They'll think they're doing something that's quite sensible because they're
Yeah,
probably
sure.
moving the way that their manual handling instructor told them was good, and it was
Yeah.
very protective for their back. So they'll be slow, stiff, putting lots of effort into it, and there might be some facial grimacing, breath holding, and there's actually people out there who have categorized some of these pain behaviors almost like a checklist. But it's that sense of, if we contrast it, people, kids, pain-free people, they move thoughtlessly, naturally, no effort, quick, easy, no grunting, no grimacing. People with pain, they think about it, they plan it, they do it with too much effort, very slowly. And I suppose it looks like a lot of effort and very little fun.
Yeah. Yeah, okay. So so you'll pick stuff up from the conversation, you'll pick stuff up in how they interact. You can certainly ask about people's sleep. What would be some questions you would ask around that, around sleep, and what would start to raise raise some queries for you, Kieran, about this needs to be managed a bit better?
Sleep specifically? Yeah, so for sure I can ask about the number of hours sleep, but really I don't know what, like when you look at the guidelines, it's as vague as 7 to 9 hours. Now I don't know, like, but that 2 hours of a difference per night, that seems like quite a range. It's
Yeah.
a bit like saying the recommended activity is somewhere between 500 and 50,000 steps a day. Like there's that's range is too big to be useful. But it would be around like their degree of how refreshed they are in the morning, and if it's interrupted sleep, whatever about short sleep, interrupted sleep is probably something that's of interest. And then particularly if it's a pattern or a recent change, and again, if they changed in relation to other symptoms, stressors in their life, or pain. There are, these kind of miraculous figures, like allegedly like Maggie Thatcher, that can survive long term on 4 to 5 hours sleep. But I know for a lot of people, there are certain life stages where, whether it's shift work or socializing when you're young, or kids when you're maybe more at my age, that there can be periods of time when stuff comes up and it specifically affects your sleep, and it's worth exploring some of those. With again, that caveat that, first of all, like all these things, we're just asking if it's an issue. We don't have to jump in straight away and address it. And I would say that if we're asking about diet or mental health like depression or sleep, even if we're not fixing it, we're just asking, could this be a risk factor? And then if it's a risk factor, we then don't have to try and fix it straight away. So for example, if somebody has stress, they don't have to get mandatory mindfulness training. Instead, we can step back and say, right, have you had this before? Have you ever figured out a way out of it? And do you think you could try that again? And while people can't always regress, because let's say, oh, I used to go to a gym class in the evening, but now my husband's working in the evenings and I've got to stay home with the kids. There's some things that logistically won't work out. But a lot of the time when people can sit back and think about it, they can actually identify, well, yeah, there was a period of time in college or when I was in my last job or when the kids were at a certain stage that I kind of got stuck like this and I couldn't sleep, or I gained weight, or I wasn't exercising. And actually what happened was I signed up for a class, or I learned to say no to X, Y, and Z. So again, if I step back in time, at one point in time, I would have thought, you identify fear, here's the fear treatment manual, and then they get better. Whereas I think there are times, honestly, that people have no sense. I've never been here before. I'm totally lost. And we might need to guide them ourselves or refer on. But a lot of the time, it's like, even opening people's eyes to it. And I'm sure you'll have had it yourself, Tom, where people will quite regularly say, I'm almost accusing me of nosiness, maybe in some ways, but like, I've never told anybody all that. And I've never really thought about how X could be related to Y. And sometimes this is the most basic stuff in the world. Like, I never really thought that moving that slowly could be a problem. I've never really thought that the sleep could be causing the pain. I always thought the pain was the only reason I didn't sleep, even though I wasn't sleeping when I was a teenager with exams too.
Yeah. Yeah, no, you're so right. So sometimes the asking of the question, which requires the patient to actually think about, is actually the first step in the management. Really, it actually becomes the management, because them connecting the dots is so powerful. Really, us telling people is less effective than people connecting the dots themselves. Really.
It is, and that's where I come back then to not give people an excuse, but it's genuinely hard to do that if you're really tight for time. Because if you're tight for
Yeah.
time pressure, it's like, yeah, come on, say the stress word so we can identify it and move on. Whereas what we're probably having to do sometimes is let the person meander a little bit and find their way, and then we can say, oh, that's interesting. You mentioned that. What did you mean? And, if you have unlimited time, I won't say it's easy, but it gets a lot easier. So it doesn't, I'd be quite comfortable with the idea that we don't have to cover everything day one. Like even if your time is tight, establish that rapport, get them to believe this guy genuinely is interested in helping me. And we don't know exactly what we're doing first, but like there was an element of respect, interest, attention, and taking me seriously. And I'll come back the second time and we can expand on that and kind of delve into it a little bit more.
Yeah. It goes. I had a memory there of watching Peter O'Sullivan on at one of his seminars in London after I just finished my master's in Australia, where we were quite regimentally trained in how to do an assessment, and these are the questions to ask and everything. And Peter's approach was completely different. He sat back, relaxed, crossed the legs, no pen and paper in hand, and just got the patient to speak, asked about their story. And obviously he's speaking very much in a conversational tone, but at the same time, in the back of his mind, he's connected, he's putting pieces together, he's pulling out the relevant information. But the approach and how he could put patients at ease to be able to tell their story, I mean, that bond, that rapport that he could develop with the patient in a short space of time was really beautiful to see. So that was very influential in my own practice.
It is, and look, I'm highly biased towards Peter's approach. He's been a huge influence on me, PhD supervisor, co-author. So, I obviously think that's, probably a good exemplar of what practice should look like. But again, he's a highly experienced clinician. He's been doing this for years. And in those workshops and in his practice, he has lots of time with people. So, learn from those things, but then don't beat yourself up if it doesn't become easy automatically, and don't expect that all people get it day one. And these are genuinely challenging things. And even like we've all done things differently. And even if we sometimes know that we could probably look at some of the old school approaches, all those approaches had something to go for them. So for example, I did the McKenzie courses, the basic ones, years ago. I don't necessarily think in a McKenzie framework now. But actually, if you go back to Robin McKenzie, he was one of the first few people to do several key things, such as like looking at different groups of patients, that they don't all need the same exercise and approach. And he had a huge emphasis on self-management. And if you look at all the guidelines now, that's front and center. And he was advocating that, I would argue, for a lot of other people. Absolutely. And so the mechanisms and his understanding of what was going on probably isn't the way I view it now. But that doesn't mean it was all wrong. And if you look at, we'll say, John Sarno's work, a very different approach, looking, very much, if you think I'm delving in the psychosocial factors, that's going hardcore for it. And some of the his explanations of the mechanisms underpinning pain, I don't think now stand up to our interpretation of it. But actually, that doesn't mean the questioning, the assessment, even the treatment was inappropriate. Like they just had not recent now, it's probably 2 years ago, a trial using the same approach. Very impressive data. And again, using a different approach to what we use. But honestly, when you step back, these are still biopsychosocially informed approaches. There are multiple ways we can help people. And it's fine. Some might be more informed by one approach than the other. But it is still looking at all the pieces.
Yeah, sure. It probably comes back to what Peter said to you a few years ago with regards to, we've got multiple entry points. There's multiple factors at play, and that's why a lot of our interventions maybe have effects across a number of different domains. And so you could kind of choose your starting point and maybe choose your own priority. But as you delve into patients' situations, you can start to see a lot of crossover in what you do,
Exactly.
Yeah. So, specifically around that kind of being able to, in your assessment of these issues, is there any kind of outcome measures you would use traditionally? Do you give patients any forms to fill out prior to seeing them?
So dividing this in two, if it's in a trial, we'll kind of overburden the poor people with as many outcome measures and questionnaires as we can. Sure. In reality, in clinical practice, it's a very small number of measures I do, and that's basically because it's pragmatic. And actually, while we can, obviously, there's a whole range of outcome measures. I'm particularly interested in using questionnaires like the Subjective Health Complaints Inventory. So it asks them about their general health. So yes, have you depression, anxiety, but also have you got constipation, diarrhea, fatigue, eczema? So a broad sense of are they run down, and that's particularly relevant with multi-site pain. Now, there's a whole series of questionnaires that are useful, and you've got the start packs and the Arbros as well that are very good at a high level profiling level. And I would say for anyone, but particularly young clinicians, they can be useful. If you think you're missing anything, maybe they're a good starting point. But in the recent, for example, trial we used the our Arbro profiling questionnaire with the subjective history, and I suppose that's ideal. But if you're an experienced clinician, I would argue, yes, you won't get everything, but I don't judge yourself if you're not doing loads of questionnaires, if that makes sense. By all around, what I would say is it's always worth looking at questionnaires and looking at what they're asking. The highly predictive questionnaires, they're never in one domain. They're checking some of how bad is your pain, how spread out is your pain, what might be argued to be biological, but they're also asking about how you're coping with it. Do you know what to do when it gets sores? Are you worrying about it? Are you feeling sad? And they'll ask them in different ways and different time zones, but they're remarkably similar. And for that reason, it's not surprising that they correlate with each other.
If I could pin you down to one, so we've got a lot of busy practitioners listening to us. If they said, "Look, I just want one outcome measure that's going to be a bit of a catch-all, it'll be the best that I can use."
I'd say, yeah, if it was one for every body site, I'd say the short form Arbro, 10 items. It's not specific to any body part. It's only 10 items. It's reasonably quick to use. There's online versions of it, and you can use it as an outcome measure, but I'm primarily using it as a profiling piece to give you a sense of. And nominally there's a threshold that if they're over 50, they're considered high risk. But let's not kid ourselves. 51 and 49 are not miles apart. But obviously, the higher the score, the higher the risk. A useful starting point.
And do you reevaluate that at the end of treatment to see whether they've changed?
You definitely would if you're in a study, but honestly, if the person's feeling better in a practice, again, it very much depends on what you're doing. And in theory, in years to come, we'd like to think we'll have electronic health records and it'll all be seamlessly integrated and we'll have registries of data. But look, the person's goals are probably as important as anything else. So if the person came in and they said, I wanted to run and play in the garden and jump on the trampoline with kids, and I can do those things now, and it might hurt a bit, but I can do them, I think that's a big win. And I'm sure their Arbro will have improved as well. Sure.
Okay. All right. So we've got the patient in the waiting room. We've given them the Arbro short form. We've had a quick scan. We can see maybe there's some things that we're going to maybe delve into deeper. We've kind of covered the low hanging fruit of maybe seeing, are they worried about their diagnosis or their scan? We've had a look around their movement and seeing whether there's any sort of kinesiophobia or fear around movement. And we've kind of talked a bit about sleep. But how do you actually, how do you broach the topic? What's the nuts and bolts? So when I think about this, you don't go straight out and say, well, tell me about your childhood and your interaction between when, you fell off the swing and your back pain, although some patients are very quick to tell you that, it all started when I was 11 and I've had pain for the last 30 or 40 years. It is still a stigma, both in our profession and in societal. How do you start to delve into that and get patients to start to talk about these issues, particularly those patients who you see beginning to clamp up a bit or maybe aren't comfortable speaking about these things?
Sure. So first caveat here, I'll tell you what I will do. That doesn't mean it's the right way. And this reflects that I'm a physio who came from a background of doing movement. And so it probably still, even though I talk about these things, I'm still probably most comfortable exploring movement and looking at getting people how to do it. So that's what I'm going to talk about. But bearing in mind, if we look at this scenario, I think, let's say you've got somebody who's in a highly stressed environment, they're inactive, they're not sleeping well, and they're scared to move. I'm quite comfortable that if they said in the past, I used to do yoga or mindfulness to de-stress, that's an acceptable starting point. Or if they said before, what I used to do is I used to do body scanning before going to sleep. That's what helped my sleep. We can start there. So a whole range of starting points. But for me, if there's anything around an inability or a fear to move their spine, particularly bending, and they're willing to explore it, that's where I'll go. Because it's often in the short term an easy thing to fix. Because a lot of the time, Even this week when I saw a patient, we were dealing with short-term and long-term problems. So it was her third session. I saw her, first of all, 2 months ago, and she had made great short-term improvements in her confidence, physical mannerisms, and moving and bending. But now we're dealing with that messy stuff that actually she still gets flare-ups when she's rushing and stressed. And that's the stuff I think we need to look at long-term. So where do I start? First of all, it might be things as basic as what are your mannerisms when you're moving and bending? And so, for example, I may as well demonstrate, because what we're really talking about in a lot of the evidence is, broadly speaking, people are different, but an awful lot of time we want people to end up moving further, faster, with less effort. So I'm not telling a lot of you anything you don't know, but even if it's, I'll do sit to stand because I'm sitting, but that sense of people when they're back pain, moving with a bit too much effort and hyperextending and using the hands and grimacing a little bit when they're down, and using some mirroring. So sometimes on their phone, videoing them and what are you noticing, and then demonstrating how I do it, and then mimicking how they're doing it, and caveating that, of course, with the idea that I'm not trying to take the piss out of you, I'm not trying to be mean, but how you're noticing that when I do it, which looks easier, when I do it like that or do it my own natural way. And sometimes taking the emphasis away to another part of their body. So, for example, if their shoulders are pain-free, getting them to do slow movement, lifting maybe a 2 kilo weight. So how heavy and easy does that feel? Versus doing the same thing quickly, getting them to appreciate like a little behavioral experiment. So, the slow movement for my body in general is actually harder on my body. And that might seem counterintuitive, but would you be willing to explore how we'd make that? Could we try faster movement or movement with less effort in your body? And so we might physically, practice that and try moving faster and look at what that does. And if people are still too scared, we might have to step back and think about how they'll conceptually get it. And so again, these are not my ideas, but people like Peter O'Sullivan and others will have talked about getting people to think about the importance of gripping. So Peter will often talk about that clenched fist analogy, which many of you will have heard about before, but explain to people that if you picture your spine being like your wrist, that you can make it move, but it will involve lots of effort and sometimes crepitus and creaking, and we can stretch it and force it and make it move. That's okay, but sometimes it'll be a bit sore during or after. But before we do any of that, it might be an idea to unpack that movement and relieve the movement and let your body move rather than forcing it to move.
Sure.
And so there's different kind of ways in there. And so, for example, if it was somebody who was willing to explore that sense of movement and was moderately afraid but was amenable to looking at it, we might look at getting them to bend in if they're quite scared, 4-point kneeling or supine or sitting or standing, but as ambitious and as heavy load as they're willing to risk and feel and still feel comfortable in. And if it's too, I suppose, confrontational, back it right back and get them to think about, well, even if we're not looking at your back, the concept of fast movement or less tense movement and so on. And so that's then our introduction point. And typically when we ask people and they experience that, yes, it's actually better when I'm going slow. If you ask them, and why? Why do you think you started going slow? And they'll typically say things, well, I was afraid. I thought I was protecting. I was worried. And then why were you worried? And have you had many worries? And where does that lead? And again, so that can sometimes delve into other things we need to talk about. Or even if it's that case I spoke about this week, the sense where they get spasms at times when they're rushed or stressed. First of all, the person needs to identify that there's a pattern, that there is actually a connection. Now, that doesn't mean that they can fix it, but what do they think is happening and what can they do in terms of their muscle tension physically, but also in terms of maybe structurally? Can we avoid that some days or some times of the week or year or less are so rushed?
Yeah. So, and I think that's a really nice one for a lot of clinicians, because that's what people will come to see us for, those physical aspects. And as we start to address behavioral change or cognitive change through movement, which is what people are expecting us to at least assess movement, it provides maybe an easy entry point, right? The question I'd have around that, and I recall, as I said, going back when I first saw Peter do this with patients who were really quite fearful of movement. Looking back now, I can say, okay, those were clearly fear avoidant patients or kinesiophobia, and he would ask them to move. He had his confidence. He had their confidence, as I said earlier, by in that beautiful manner that he has, and they would then move beautifully, and a picture of wonder would come across their face, like, oh my God, I can move again. All right, so that's the gold standard. That's beautiful. But what happens when you get patients to move, as I did when I saw Peter, said, okay, I'll just get people to do that, and maybe you would get them to move and they're not moving with fear, or you reduce their fear and they still have pain, and that's the tricky one. Okay, moving freely reduces their pain, but partly people have fear of movement because every time they move it causes pain and it validates their fear and it goes round and round in circles. So what if you have changed how someone has moved, got them to relax and move, and they still have pain? Where do you go from there?
Sure, yeah, and for sure that'll happen. And I think when that's happened with me, when I go back and look at their history, there's probably some signs that it wasn't as. Now, we're not saying any of this pain is purely mechanical, but they tend to be even less mechanical. So the presentation I'm thinking about in those situations is this person with the chronic widespread pain, lots of fatigue, lots of sensitivity in general, and they'll have some abnormal patterns of movement. But even if you relax their shoulders and get them to breathe a bit, they might move a fraction better, but nothing in the overall scheme has changed in terms of their overall disability. It's not a light bulb moment, oh, now I can go for it. And so again, we're speculating here. I don't have strong data on that, but that's where I feel the movement component, if we look at those various contributors, like how much of this is theoretically lifestyle, psychological, social, physical, where that physical contribution from the way you're moving, the way you're loading your spine is a bit less. And my suspicion is that's where we're dealing with more of the widespread sensitivity, the chronic fatigue, the irritable bowel, and so on. And that doesn't mean we can't help them. In fact, it's useful. If I'm trying something and it isn't helping them, it's like, right, maybe I can try something different, or maybe it's just a reminder that actually there's something else we need to look at.
Yeah. It's of the people I see who maybe have come for a second or third opinion. Some patients have gotten defensive or felt that previous physios haven't been going the right direction with their management because they have asked about psychosocial issues. Let's say, all they wanted to do was talk, or all they wanted to do was to tell me that my fear is related to my pain. And I can look at them and I can see that there is a component of that in their presentation, but maybe either the way the therapist may have gone about explaining it, or maybe the fact that their presentation hasn't really got the dominant issue isn't fear, can be quite potent. So how would you kind of lead into a patient like that, maybe who is a bit defensive when you start to come at these things, and they're a challenge?
Yeah, it is. And again, trying to be respectful, but equally, we talked about identifying risk factors, but a risk factor for me is if the person comes in and said, well, I saw 3 physios before and they were all useless. They might truly be useless, but that doesn't fill me with confidence about my future rating on physiorating.com or whatever it is, But I suppose,
is there such a site?
No, but I'm sure that there's probably a boards.ie or something like that. But I guess, look, it's easy for me to say, well, that they clearly were rushing it or used the wrong words. I wrote a book chapter last year, or I contributed to a book chapter, and I gave the example of how I saw a person with shoulder pain once, and they spoke about their pain and how it was really bad when they were very frustrated. But I didn't use the word frustrated. I said stressed. I wasn't paying attention. And I started talking about how I think it's dealing with the pain might be connected to his stress. And he got quite agitated about it. And then we got to the bottom of it and calmed down in the end. But basically, in his view, he was frustrated because he was getting screwed by his employer and they were treating him badly. And he had reason to be frustrated. Whereas in his view, stress was for wimps and weak people who just whined about stuff. And they were not the same thing at all. And so I think I could have been one of those physios in that way, that I was listening, but I didn't use the right word. Or actually, maybe as I've done before, I think I know where we're going, so I'll just skip ahead now, Tom, and tell you because I'm on the clock. And again, I do think that time thing is a bit of it. And I think that comes back to sometimes our insecurity that I must fix you in the first session. Instead of sometimes saying, right, we've learned a lot today, don't rush it, keep them happy, keep them coming back. And look, that doesn't mean they'll all believe it. Even if you go back to our first discussion, the societal stigma, I think where that'll become more less challenging is actually if, in a compassionate way, GP, physio, surgeon, employer, manual handling instructor are all coming to a similar message. Whereas at the moment, in fairness to patients, it's all over the place. The different mixed messages they're hearing between physios, never mind between the other healthcare professions. So I think it's genuinely hard. But I suppose from my perspective, we go back to that physical thing of the movements. I think there's great face validity. So, for example, in the same way I'm joking that as a physio, people want to strip. But I find it's a less confrontational approach to at least look at their posture, their movement, how they interact with their body, the confidence, the fear, the freedom. And I see almost no patients that are confident in their spine by the time they see me. And so it's an easy in. I could argue maybe somebody would look at it and say, oh, well, you're just pushing the can down the road, like you're delaying the inevitable hard conversation. But I see it as being both useful for their condition, but buying me credibility, establishing rapport. And then we still have to say, now, how do these things connect? And really focusing on, now I see there, it's a bit tense. What happens if you relax, and does that change? Because even if we think there's a huge psychosocial contributor, if you look at, you mentioned your mother's a clinical psychologist, you would, I suppose, psychologists would argue sometimes that the underpinning mechanism to a lot of what they do is exposure. You know, at some point you can do it in different ways, but like, especially if it's a phobia or a fear or an avoidance, whether it's spiders or airplanes or small spaces or large spaces, there might be a graded element to it. But to truly overcome the fear of spiders, there's going to be spiders involved, but they might be physically crawling on you at the end, but they might start with thinking of them or looking at pictures of them or looking at them through the window. But you're not going to get there without addressing some of that. And so if the person's petrified of bending, you can't just talk it out of them. You can explain the biomechanics, you can explain the scan isn't bad, but until they bend and maybe do it 1,000 times and the world doesn't end, they're understandably going to have a fear. And again, that's where I really think we have to understand that the bending inability, it's not just about biomechanics and discs and muscle activation, but actually the bending or the rolling in bed or the lifting, we still have to keep that as part of our rehab.
How there was two things that come to my mind. The first thing that comes to my mind is I had quite a fear of spiders as a child. Not sure why, but living in West Cork in Ireland, I would arguably say we've got the biggest spiders in Ireland, and they're getting bigger. They're massive. Anyway, my dear brother put one on my back when I was a child, and they were always scuttling about. Anyway, one way or another, I developed a fear, and then moved to London for a while and didn't see a spider for ages in a big metropolis, and then so I didn't have to face it. I went to my master's in Australia, and I had my own apartment. And my God, did I have to face it? You know, there was no
with bells on.
There was no. I remember coming in the door after a late evening of lectures and study. It was around 11 o'clock, and I was just tired. I just wanted to come in, and there was a huge huntsman spider right in the middle of the floor. Easily the size of my hand, and he was between me and the fridge, and I was starved. I said, right, we just have to do this. We have to do this, Tom. So I grabbed a big glass pot, snuck up to him tentatively now, and then put it over him, slipped the paper on, and got out. And since then, and other aspects like that happened multiple times in Australia. Wouldn't say completely cured. I wouldn't say that I'd like to be in bed with a few of them, but the fear and the threat level goes down, and to take your point about movement, it's probably no different, right? And the fear of movement is one thing. The fear of pain is really the aspect. And those patients who maybe who continually say, yeah, I'm less fearful of movement, but I still have pain, and the pain is really annoying me. How do you maybe de-escalate that a little bit? People get really frustrated, and of course the main thing people come to see us about is pain.
It is pain and all the consequences. And again, if it's sometimes though, there's a sense, we even in our students now, we wrongly give them this formula. You do the history taking, then you do the physical examination, then you do the treatment, and it's like in that neat order, whereas actually, as you said, you see the person, there's objective observation happening. And actually, sometimes you can ask the history, do some objective tests, and it all kind of fits in together. So it's kind of it's hard to know how we all kind of tie those pieces together, and how we kind of move forward with I suppose where we are going with that into the future.
Yeah. There is an acceptance, I suppose, is where I'm thinking that we have to have that conversation with patients that maybe they won't be pain free at the end of
Yeah.
at the end treatment. I think that's important conversation
Like
to have
I
early
can think
on.
of some patients I've seen where they'll say things like, when I'm in pain, as I've seen them for a couple of times, they'll say, well, when I'm in pain, it's the pain, but also I'm thinking about, well, what's going to be the consequences? Am I going to be sore tomorrow? Will it be worth it? I'd like to do the gardening now, but is it worth ruining the whole weekend for it? And even if they get a chance to verbalize some of those thoughts, that's a chance to think through them. And like and it'll apply to bending and gardening, but there's a dance or a wedding this weekend. Will I wear the heels? Will it be worth it? Will I be sore? But then I'll feel like I'm missing out. And look, for a lot of these things, it's not about living a life without pain, but kind of looking at your own values and what's important to you and what's good for you and not so good for you, and your own preferences. And sometimes that's a bit time consuming. So I think, again, for us, all we're really trying to do in the early days is ask everything, get the person's trust, get them to start on some things and see some progress.
Yeah.
And then the tricky part can be then, if you're getting progress with a certain range of things, how do we get them to scan wider and kind of start really looking? Because my sense is a lot of these people have been helped a little bit before. They have a flare up, they get helped a bit, they struggle on, they're not bad, but it keeps happening. And I think to really, and we're not saying making them pain free forever, but to really make a change, they have to step back and see how the different bits and pieces are connected.
Yeah. If I think about, prior to this conversation on the drive in, I was thinking, what are the patients who are maybe easier to manage from a psychosocial component, and they'll be the patients who really are the ones who are quite naturally introspective or who have connected a few dots themselves. So I think about a number of patients who've come in and they'll openly say to us, okay, yeah, I've really noticed. You'll ask them, have you noticed anything, around your stress, or are you stressed in your life or anything like that? And they will openly say, yeah, I'm stressed, and by God, when I'm stressed, my pain goes through the roof. All right. So there's a beautiful entry point. That's a different presentation to someone who really is very closed, and you need different ways of kind of talking with both. But the person who's very already on that path to kind of thinking about their pain is a much easier one to manage.
Oh, for sure. And again, even if it was around, I mentioned the fear of movement, there'll be people who will honestly say, no, I'm not afraid, but looking at them, there's something inhibiting their movement. And look, we would love to get to a point that into the future, when you and I are long retired, maybe, Tom, but when a person presents to a physio at back pain, they say, look, I hurt my back digging in the garden the last day. It's been a really busy couple of weeks. I've been stressed and not sleeping. And I think, between the build up of stress, not exercising, a bit sleep deprived, and then I did something I hadn't done for a while, I think it all just became a bit too much. So now that I've figured out those factors, I'm coming to you for the rehab. It'll be lovely, and that's societally acceptable, and people have that understanding. But in the meantime, we're probably going to have they'll come in with some of that history, and it's our job then to try and not kind of lead them, but make sure we're asking about all those bits and pieces. And I still see patients where there's things I'm finding out on the third or fourth session where it's the most important stuff, and I didn't get to ask it, or they didn't fully disclose it. And if I'm honest, that's often some of the more sensitive stuff, some of the stuff around abuse, marital relationships, and other childhood trauma and other sensitive things. And I would never blame people for not blurting out some of the more private, sensitive things day one. But I would say in most of those situations, I wouldn't say all, I have this very non-scientific hunch that there's more going on, if that makes sense.
Yeah.
And that doesn't mean we're saying they're crazy, but it's just, we'll just keep exploring that. We've still got things to work on, and we'll keep working on some of those things. And then if we think it's a significant enough factor, that's where we're probably referring on to get the person support, if it's not just about their pain, but these other stuff in their life.
Yeah, super. So much to unpack there, really. Kieran, that's great. I'm gonna ask that if people have a few questions, they can start putting them in the chat now, and we'll get back to them. And while that's coming through, I want to maybe ask you for a couple of minutes just to talk through your maybe management process in two maybe distinct phenotypes that we might see with this. You kind of alluded to one, but it's nice to hear it, maybe how you would go about it again. The first patient is our anxious, kinesiophobic, catastrophizing, patient who's very involved in their pain. They're very, they ruminate a lot, and they monitor where their pain is and the severity of that. And I think we've kind of maybe discussed that, but that you're using how to pick that out. What are your strategies maybe to calm or to put that person at ease effectively? How would you, what would the language be that you would use with that?
Sure. So again, this is not kind of breaching any patient confidentiality, but I've already got a person in mind, and they've spoken about their story on that website. We have pained.com, and her name is Anita, a lovely lady. And again, she spoke about her story. And so if they go to patient stories under Anita, you can hear her talk about it. But essentially, in its own way, I would argue Anita's rehab and other patients was remarkably similar, but it was much more patient and slow. And I appreciate then that brings challenges, because if you're in the private sector, can she pay for extra sessions? Or in the public sector, will you be coming under pressure to discharge her? But I remember what I mean by that is there was a huge element of trust. Anita and other people like her had been to see lots of people, and we're not blaming them before, but she always felt forced and rushed to do things and to do the rehab, and she was basically petrified. She speaks about that in the video. And I think probably somebody who was maybe more charismatic or better at building her confidence could have got her there quicker, but it took me a long time to truly gain her trust, get her to realize that it was okay, that there was, that her back wasn't that damaged, but particularly she was petrified of movement and loading. And her big goal was to travel, and her barrier to traveling was she couldn't carry. She had a wheelie suitcase, but she would at times have to lift it on and off, and she was afraid because she had a spasm one time in an airport and she hadn't traveled since. So her anxiety around her back pain and the consequences for travel and all that was a big part of it. But I would honestly say there wasn't an awful lot different, other than we spent a lot of time reassuring her about movement, and we had discussions about her re-engaging with what she did to reduce her anxiety, if that makes sense. That was about the only thing that was different. And I suppose in all those kind of mental health domains, because I would say she had a mild anxiety disorder, I would consider our options in terms of onward referral to be kind of in 3 levels, the same as I would for obesity. So for example, if we see somebody who's morbidly obese, and let's say we think it's a risk factor in their overall musculoskeletal pain, because it's an inflammatory factor and so on, I think it's always legitimate to sensitively identify it as a risk factor, and then to ask them if they're okay having a discussion about their weight, and just identify it as a risk factor. At a second level, we could possibly ask them, have they tried interventions or approaches before to address that weight on their own? And if they had, could they engage those themselves? And then thirdly, there might be that need to refer on. So identify it. Can we nudge them to self-manage some of these things, or re-engage with self-management? Can they do anything? And similarly with those people with high levels of fear and anxiety, where we feel they might need some support, definitely identifying it. Have they done something, engaged with some support before? It might be their own little light touch, online CBT, mindfulness. It might be re-engaging with counseling. It might be re-engaging with social activities. It might be exercise. Or then is there another level that they need? And that's a judgment that I'm not really comfortable. I'm confident on where you draw the threshold, but my sense is, in the absence of an emergency or an urgent situation, try something, escalate or step up the care if we need after that. And I would apply that to most approaches, if it's not urgent, acute medical considerations aside.
Yeah, I think you raise a really good point there about that rapport and that story and that psychosocial interaction you had with her is a progressive thing over a number of sessions. I think we always feel that we need to nail it day one as well, and you let that story evolve, and you were able to plan then and discuss that over time. These things take time. It's not in a first assessment. It's not in a half an hour appointment, is it?
It is, and it's, depending on, in some countries there'll be an insurance system that will allow you 6 sessions, or in a public system, whereas I could think of, and I'll talk about this with students, that I'll have patients where honestly sometimes, even if it's persistent back pain, it's 1 or 2 sessions, they have that light bulb moment, they re-engage, the fear of movement goes, and off they go, and they're great. And others, and again, I'm trying not to stigmatize them, but often with it's more widespread pain, more sensitivity, or more comorbid health complaints in general, more long-standing anxiety, depression, where they need more time with someone, that might be me or other people. And I suppose, like, at times, we'd like to think there'll be a questionnaire, or nowadays there'll be some machine learning AI kind of a bot tool that'll tell us, oh, this person's going to need 4 sessions of X and 2 sessions of Y, but I don't know that we're that predictable. But I think we have, and it's like one of those things, when you look at red flags, Thomas, like we'll say, the big predictors amongst like the, long history of cancer is a big risk factor, but a clinical suspicion, whatever the hell that is, but that is, a known kind of an identifier of it. And there is a bit of that in all these things, that it's clinical suspicion isn't enough, but it's a part of that thing that is there. Have I got a hunch here that this person needs a bit more? And ideally, we'd counterbalance that by not over-treating the acute, not keeping people going forever. And I think that's a challenge that if we that's where I too think we need better data in terms of expenditure on healthcare and spend in terms of return to work, because I think we have both under-treatment and over-treatment. I think we've, in public and private, but especially in private, we have a lot of over-treatment of routine conditions. And then we have, I would argue, disgraceful under-treatment of people with chronic conditions. And again, that treatment doesn't have to be in a hospital, doesn't have to be a physio doing hands-on, but support from allied health professionals. And we probably need to just rebalance. It's not all about more money, but where are we spending the money we have?
Yeah, great point. Great point. Okay, on the other end of the continuum, maybe, well, on a different end of a continuum, is the patient maybe who's more on the depressive spectrum. So they're more low mood. You ask them questions, you'll get a very flat response. They have or have not got a diagnosis of clinical depression. They might be on antidepressants. And those patients, that can be hard to get them engaged, but also to maybe change behavior if that's possible. How do you address those patients? They present with pain. You ask them, how's their pain? It's the same. We ask them to move. How's your pain? It's the same. How do you lead into that maybe you can address those things in clinic?
So again, I suppose my sense is, as well as asking about their pain, their form, their energy, sometimes it'll be asking them, what did you do with the weekend? What are your hobbies? What were your hobbies? Why aren't you doing them now? And if there is a repeated pattern of like kind of monosyllabic responses, not much facial expression, but particularly nothing happening, disturbed sleep, disengagement, I think bringing up their mood, and if they've previously spoken to anybody about their mood, had any medications, they're all things worth exploring. Now, I'm not saying this is our job, but I guess, at some point along that conversation, the real question is now, do I start thinking about asking them, have they thought about harming themselves? Have they ever engaged in any self-harm? And that's something that I think we rarely need to ask patients, but equally, if it's something that's at the back of our mind, we should ask them if we are ready for their response, because that's a different thing. And I suppose what I would be reassured, Julie Sugru from, she's like yourself, Thomas, she's a triage physiotherapist in Croom in Limerick, and she's doing a PhD on looking at significant psychological distress in people with low back pain, but particularly those with suicidal ideation. And one of the things I've learned from Julie is that it's pretty clear that we'll say there's a big distinction between people having suicidal ideation and suicidal ideation and a plan, if that makes sense. And it's really, in terms of psychiatrists kind of being concerned, it's the people who are not just having suicidal thoughts, but having suicidal thoughts and a plan for this thing next Thursday. That's when we really kind of need to escalate care, if that makes sense. So there's no suggestion that by asking people, have they thought about it, that we're planting any thought like that in their head. And again, I would just raise that in terms of, that's a conversation I very rarely have, but it's something that I would be more comfortable having now in that small minority of people where they are reporting with back pain, but actually, as you explore their history, the back pain is a secondary or a tertiary complaint relative to their poor mental health. And I suppose how significant their depression is. Yeah,
I can certainly think of one or two instances where people have volunteered the fact that they have thought about suicide and things like that, and that's something that we really need to be cognizant of. But it is the minority.
And then I suppose the challenge for us there is that we'll say it's comfortable for us sometimes to say, well, they're the non-responders to rehab or CFT. But when you look at the surgical trials, these poor people are also the non-responders to surgery and to spinal cord stimulators, and they're often the poorest responders to weight loss therapy. And that doesn't mean we give up on them, but like we would all like to take the easy ones and the responders who have one pain site and are otherwise healthy and are annoyed with the back pain but otherwise happy. But we probably need to keep an eye on those people and give them better support services. And again, we'll consider depression as a psychological factor, but significant depression and the social supports around it, they're highly connected, in my unqualified opinion.
I'd say you're more than qualified, but point taken. Okay, Kieran, just looking here from a question point of view. Questions come through regarding the RESTORE trial, if you like. In the RESTORE trial, there's a high exclusion rate of over 51%. Clinicians can't exclude patients like this in everyday practice. What are we supposed to do with the excluded? So you might tell us who was excluded, why were they excluded, and maybe how we manage that.
Sure. I know David had sent this question. David Poulter had sent in a question like this, or I saw him flag it on Twitter. Yeah. I know David a bit. I went to one of his courses a number of years ago. I like this question for two reasons. It's a really important consideration in general in every trial, because trials have a real habit of picking and choosing certain people. So if you really want to see me, along with maybe Donald Trump and other things getting me riled up, is if I'm asked to review a grant where they say back pain costs billions and it's a huge problem, and therefore fund our trial where we're excluding all the messy ones. Anybody with comorbid leg pain has ever had surgery, has other pain sites, has ever had compensation, and you end up with these people that are a bit stiff and sore and are otherwise fine. They're not the ones costing billions. Yeah. So I'd rephrase David's question one way. He was saying it was a high exclusion rate of about 50%, and that's true, the number's right, but I'm going to call that a remarkably low exclusion rate. So I was looking at what's typical in trials. And the reason, now we'll talk about the kind of ones we left out, but I just had a quick look at kind of what's representative. And in the 6 other biggest trials, the inclusion rate varies between 6% and 19%. In other words, it's typical that in a back pain trial, for every one patient they exclude about another 4, whereas for us it was 1-to-1. And one of the reasons for that is we had very flexible inclusion criteria. So I actually went and looked at one of them, and one of them had people excluded if they'd spondylolisthesis, which is, it's arguable whether that's a specific pathology. If people had previous surgery, which we included. If they had a body mass index greater than 30, I'm not far off that myself. Or if they'd ever been involved in compensation. So whereas when we excluded, if I look at the ones we excluded, and I have some numbers here, we excluded the 3 biggest reasons for people being excluded are the common ones. They were too good. So if they had less than moderate pain interference, so we wanted people that were pretty bad. So if they'd
complaining about them, so
yeah. So if they had less than moderate pain interference, 95 were excluded for that. 85 were excluded because their pain was less than 3 on a 0 to 10, and 41 were excluded because they had pain for less than 3 months. The only ones that were excluded because they were potentially too bad, there was 37 that had potential serious spinal pathologies, so they had to be triaged. 16 didn't have English, and then there was we included people who were undergoing compensation, and let's face it, that's a really tricky group. But there was 12 where we didn't get permission from their case manager to include them, so they would truly have been 12 different cases. Okay. So going back to David's point, it's a really important point. Do my patients look like, or in my clinic, look like the people in that trial? And if they don't, that doesn't mean the people in the trial did anything wrong. So if I look at that wonderful start back trial I spoke about earlier, I still think it's one of the best trials that's been done in back pain. Having said that, the average pain duration for the people with back pain was 6 months. And I'd like you to think about, well, how representative is that of the people I see in my practice? I know in most of the waiting lists in Ireland, it will be a hell of a lot longer than 6 months. Mm-hmm. And that probably tells us why the self-management option in the start back did pretty well, because I know a certain amount of healing will have happened after 3 and 4 months, but actually 6 months is still fairly early, and there was probably quite a few people who were still in the relatively early stages. And when they've tried some of those self-management start back interventions in the chronic low back pain group, there's been a couple of different trials in America and Denmark, it doesn't quite look as impressive. Not because they did anything wrong, but because they're a different population.
Mm-hmm. Okay, look, I think that's really great the way you've answered that. And ultimately, that RESTORE trial, it actually was looking for people who had significant enough pain. So, as you said, other trials have shied away from other things. I think the RESTORE trial was very good at bringing in
I think so. For example, if I had, we'll say, not concerns about the trial, but concerns about the approach, it's probably more around like the challenge of upskilling enough people. And again, it's not that it's about a certain amount of hours, but all of us have probably come from a perspective of being more comfortable in certain areas. And so how do we train enough people, not just in our approach? Let's take about Sarno's approach, or biopsychosocially informed approaches, and do that in different languages, in different countries, high income, low income countries. And while there are some steps ongoing in that, it's a real challenge. And doing that at a time when maybe other professions or healthcare insurers or governments don't want to fund the stuff that works. So for example, I'm a physio, I'm biased towards physio, but I think we should be funding stuff that works and not funding stuff that arguably doesn't. And then there's obviously stuff we're less clear about it. And some of that stuff that works can be done by physios, and some of the stuff that doesn't work is done by physios. And so we need to separate those out.
Yeah, super. Okay, Kieran, I think we'll wrap it up. There's one question actually from a colleague of mine, Rob Madden, who great physio, wants to know about what do we do with people who have quite firm belief system, e.g. wearing a back brace to train, and they really don't want to let go of that. Do we nudge them to let go of that? Is it okay for them to keep
to keep their comfort blanket? It's an interesting one, isn't it?
Comfort blanket, correct.
Yeah, it's tricky, because it's probably not as straightforward, because with the ankle braces, for example, there's a bit of evidence that the braces can be pretty protective, like that it's for some people a protective strategy. I guess my sense would be, so this is only opinion, Rob, so take it or leave it. It's a kind of is the juice worth the squeeze? So will it make a big difference to them regaining confidence? Because I presume we're coming from the perspective that that's a comfort blanket, a crutch. We need to reduce their dependence on it. And if we felt it was going to be useful, then go for it, and compassionate confrontation, take it on from a point of view of kind of being respectful. But equally, it's like I go back to I won't waste my time saying there's one guy on Twitter and I happen to disagree with him, so I've got to take him on. It's almost like, can I live with it, if that makes sense? So sure. Things aren't always optimal. I think it's a tricky one. I could be persuaded either way. I'll have people where they're still persisting with some, you could argue, pain behaviors that I would consider aren't ideal or necessary. Do they really need those fancy shoes, those particular orthotics, that kind of fancy chair? But if it's I can live with it if I don't feel it's actively harmful, if that makes sense.
Mm-hmm. Great. All right, Kieran, thank you so much. That's been fantastic. I really hope that the listeners and viewers have taken a lot out of this. As I always do, 3 quick little questions to wrap up. Firstly, have you a top 1 or 2 or 3 articles, references that you would advise clinicians on this topic to find out more? And we'll add these to the show notes.
Sure. I guess one of the challenges there is, in today's world, who wants to be reading books and journal articles? Because I'm highly biased, the Restore trial was published, and there's a website, Restore Back Pain, which Peter O'Sullivan and Peter Kent have led, and that has lots of useful information about the intervention and patient stories. And I'll flag that almost because sometimes clinicians might like a place to send patients to listen to patients talking about their recovery. In terms of if you're going old school, old printed books, or Louis Gifford's books would always be highly recommended in terms of, how, a bit like Waddell, it's dated very well and it's insightful. And look, any chance people have to hear the likes of Peter Sullivan, Laura Mosley, and these people, I would recommend it, especially nowadays online. You can still find a lot of good information there.
Yeah, super. If we were to distill everything that we've talked about tonight, we've talked for a bit, what would be your key clinical takeaways for the clinicians? What would you really want people to go home with?
I would say that pain is a biopsychosocial experience, and physical rehab is one part of what we do, and understanding how psychosocial factors inform that rehab is really important. That doesn't mean we have to treat them all, but it definitely means we should inform them. And while I would say, if I was feeling really optimistic, I might say, and in 20 years we can dump it all, because society will have it figured out and there'll be loads of psychologists and social workers to take care of that. In reality, nobody's going to treat these people with a multidisciplinary team anytime soon. So pain is a big biopsychosocial thing. It's not our responsibility. It's not your fault if they can't cure them. But at the very least, ask them about everything and then do whatever you can within your skill set. And maybe just think about if I'm doing manual therapy, that's a perfectly reasonable starting point. But what words am I using that could reduce or increase their fears and anxieties? If I'm doing exercises, will these exercises make them feel strong and confident, or will it make them feel strong but nervous? If that makes sense.
Beautiful. All right, Kieran, where can we find more about you? Where are you? Where do we find you?
So, in a couple of years ago, I would have said I'll be on Twitter, and it's at Kieran O'Sullivan, but actually I'm spending less and less time on that particular app. But if people Google me, I'll be at UL, so Kieran.O'Sullivan at ul.ie. But in today's world, if you Google me, that's probably the easiest place to find me.
You've migrated to TikTok, I assume.
I'll be one of the creepy middle-aged man hanging around on TikTok.
Absolutely.
No, and I guess the other thing is, same as I mentioned, Restore Back Pain. We have a website, pained.com. People can go on there and they can look at some patient stories there that might be useful.
Great. Kieran, thank you so much. World-class speaker there. I hope that we've delved into this sufficiently for clinicians to pull lots out of this and be able to use in their clinical practice. It's an ongoing conversation. This stuff is evolving all the time. So we'll hopefully have this conversation again in a little bit, and things might have changed. Perceptions might have changed. Research might have changed. Kieran, you're a gentleman. Thank you so much.
No worries. Thanks, Thomas. Thanks for the opportunity, and good night, everybody.
Yeah, take care. Okay, thank you, Kieran. Fantastic. I hope that was helpful for everyone. Thank you for your engagement to those who've come. I will see some of you in April for my course in London. And I wish you all a very good evening, and we'll catch you again on All Things Spinal. All the best.